is Amy Spigelmyer, and I'm one of the infectious diseases clinical pharmacists here at Ruby. And I'll be presenting the didactic portion of today's topic, which is antimicrobial suppression. And I'll be focusing specifically on infective endocarditis. Next slide. So by the end of today's brief presentation, I only have one objective for the group, which is that you should be able to describe the ambiguous nature of antimicrobial suppression in infective endocarditis. Next slide. So before we jump into infective endocarditis and suppressive antimicrobial therapy, I did want to take a step back and just discuss antimicrobial therapy or antimicrobial suppression as a whole. And so in general, antimicrobial suppression is described as long-term or indefinite antimicrobial therapy to prevent symptoms, infection progression, or relapse in patients with an infection that is presumed to be incurable. In a 2024 review article that sought to describe the primary literature that's been published on suppressive antimicrobial therapy, or SAT as it'll be described throughout the presentation, this review article found that these are the most common four indications for suppressive antimicrobial therapy. So prosthetic joint infection, vascular graft infections, cardiac implantable electronic device infections, and orthopedic hardware-associated infections. Now, what this article found is that while the literature is not robust in these patient populations, there have been numerous small studies, but because the variability in the patient population, it's really hard to determine exactly when we should be prescribing suppressive antimicrobial therapy in the patient population. And so a lot of providers will actually approach these situations very differently. And so I did want to take some time and talk about some of the variability that we see in suppressive antimicrobial therapy prescribing. Next slide. So here we actually have the results of a survey that was published in 2024, but conducted in 2022. The group that published this article surveyed over 400 infectious diseases providers in North America, and they specifically inquired about suppressive antimicrobial therapy prescribing in osteoarticular infections. So not so much directly related to infective endocarditis, but we can extrapolate some of the responses to the patient population we'll be discussing more in depth today. And so on the left-hand side here, this is how the responders had answered a question about the percentage of patients that they would prescribe suppressive antimicrobial therapy to who had either a DARE or a single-stage exchange. So you can see that over 200 of the providers that responded to the survey said that in more than 80% of their patients with a DARE, they would prescribe suppressive antimicrobial therapy. But that number of responders that said yes to SAT in that patient population for DARE actually dropped down to about 140 for a single stage exchange. Whereas you can see our providers answered slightly differently for between 20 and 79% of the time for either a DARE or single stage exchange. So we have quite a bit of variability with our providers choosing to prescribe suppressive antimicrobial therapy depending upon the intervention that was chosen. On the right-hand side, the authors of the article looked at the intended duration of suppressive antimicrobial therapy. And so of the responders to the survey, you can see here that 40% said that when they prescribe suppressive antimicrobial therapy for osteoarticular infections, they intended for it to be lifelong, whereas 24% said that they intended it to be only 1 year. 24% said other, which really means patient dependent, and then 12% said this should be determined based upon follow-up studies, whether that was imaging or laboratory monitoring. So this specific study out of North America showed that our providers definitely vary as to how they approach suppressive antimicrobial therapy prescribing and duration. Similarly, on the next slide here, we have actually a global survey that was also recently published in 2024 in the Journal of Infection. And instead of only focusing on the decision to prescribe suppressive therapy and the duration, they also focused in on the agent to be chosen, as well as the dosing. And so here on the left-hand side on this bar graph, you can see that in Staphylococcus prosthetic joint infections, when they prescribed suppressive antimicrobial therapy, the agent that these providers had chosen also varied. There were 330 responders to the survey, 100 of the providers said that they would utilize an anti-staphylococcal penicillin, and then 60 of the providers said cephalosporins and about the same for tetracyclines, but many less chose rifampin fluoroquinolone combo, fluoroquinolone alone, Clinda, or linezolid. And then a little over 60 of the providers said other, which could mean an agent that was not available in the United States or a combination of the agents listed here. On the right-hand side, this pie graph shows essentially how providers adjust doses when they prescribe suppressive antimicrobial therapy. So 38% of providers said that they always lower the antimicrobial therapy dose for suppression. 38% said it depends on the agent, and 24% said I always lower the dose. And so once again, we're really seeing a lot of variation in how our providers approach suppressive therapy, from the decision to prescribe to the duration to the agent and the dose. And so we see a ton of variability, and this is connected to the lack of national guidelines. And so we'll jump into infective endocarditis data, starting with the actual clinical practice guidelines that have been published. And so on the next slide here, you can see that the Infectious Diseases Society of America makes no commentary on suppressive antimicrobial therapy for bacterial endocarditis. They do comment on it in fungal endocarditis. And then the European Society of Cardiology infective endocarditis guidelines make no recommendation for bacterial endocarditis, but they do offer the following commentary, which states that data on the efficacy of long-term antimicrobial suppression in patients with infective endocarditis who do not undergo cardiac surgery are limited to small and heterogeneous series with various antibiotic regimens, and relapses are not infrequent. So they don't really provide a recommendation, but state that there is limited literature out there, and the clinical implications of the literature is not very strong or very clear. And so that brings us to kind of the one study I wanted to present today here on the next slide. This was published in Open Forum Infectious Diseases in 2024, and it was a retrospective single-center observational study. It is the SATIE study, which means suppressive antimicrobial therapy and infective endocarditis. And this study sought to describe the indications of suppressive antimicrobial therapy for patients with infective endocarditis and their outcomes. They looked at endocarditis characteristics, the suppressive regimen, adverse drug events, relapse, reinfection, and all-cause mortality. Here on the next slide, you can see the inclusion and exclusion criteria. So they did include anyone that was prescribed suppressive antimicrobial therapy for definite or possible endocarditis. This could be native or prosthetic valve, or a cardiac implantable electronic device infection. They had to have suppressive therapy prescribed and followed by the same provider or health system, and they had to have been administered at least one dose of suppression. Patients were excluded if they were prescribed suppressive therapy for a vascular graft infection without valve involvement, LVAD, chronic bone infection, or acute fever. So here on the next slide, we can see the baseline characteristics of the patients in this study. Interestingly enough, this study does comment that it's actually the largest study on this patient population published to date, which is almost funny because there are only 42 patients described in this observational study. The average age was 72, and it was predominantly male. A very small population with intravenous drug use, only one patient. 62% of patients had a history of sternotomy, and that could have potentially been directly related to their lack of surgical intervention for infective endocarditis in this specific study. And 95% of patients had some type of prosthetic cardiac device at baseline. And you can see specifically the type of devices they had here. So 64% had a prosthetic valve, 19% had an ascending aortic prosthetic graft, and 57% had a ICD. With regards to the Charleston Comorbidity Index, 54% of patients had a score of 3 or greater, but 69% of patients actually had decent independent living at baseline and were independent for their ADLs. On the next slide here, they describe the actual infective endocarditis localization that actually required suppressive antimicrobial therapy in this study. And so I know this is a bit of a laundry list here, but 21% had an ICD-related infection, 45% had an aortic valve in infective endocarditis. 17 had actually an aortic prosthetic graft involved as well. 9% had a mitral valve endocarditis. Only 5%, 5% had prosthetic valve endocarditis here. From a pulmonary valve standpoint, 5% had pulmonary valve endocarditis, but none were prosthetic. And then 5% had tricuspid valve endocarditis and none were prosthetic. And then 12% of the patient population had more than one valvular location. So a lot of variation here, mostly aortic valve as well as ICD-related infections. And then from a causative pathogen standpoint, E. faecalis and Staph aureus were the most common, but only one patient had MRSA. 14% had strep. A smaller patient population had coagulase negative staph, and then 9% had other involvement. And then on the next slide here, the authors talk a little bit about the actual indication for suppressive antimicrobial therapy. And the most common indication in the authors' minds were surgery not performed, but indicated in 67% of patients. In the rest of the patients, it may have been related to retained hardware or lack of clinical improvement. They also described the actual suppressive antimicrobial therapy regimens that they utilized. So amoxicillin and doxycycline were used in the majority of patients, either for E. faecalis and strep for amoxicillin or staph and E. faecalis for doxycycline, with varying dosing regimens. They even used 200 milligrams daily of doxycycline in some patients. Minocycline was used for one patient with Enterobacter endocarditis, and then 2 patients received sulfamethoxazole trimethoprim, and there was one patient with fungal endocarditis who received fluconazole as suppression. On the next slide here, they talked a little bit more about some of the clinical outcomes. So of the 42 patients included, 12 experienced an adverse drug reaction, most of them minor. One patient did have acute kidney failure on sulfamethoxazole trimethoprim, but improved after cessation of therapy. But other patients just experienced diarrhea, thrombocytopenia, or epigastric burning on doxycycline. 5 patients either had relapse or reinfection. So relapse, per the authors, was defined as a further endocarditis episode with the same organism. Reinfection was further endocarditis with a different organism. So 3 patients had relapse, 2 had reinfection. All of those patients originally were on suppressive therapy because they did not have a surgical intervention, even though it was indicated. But all of these patients were adherent to their suppression at the time of either relapse or reinfection. And then overall, 14 of the 42 patients died during the follow-up period, and there was 1 confirmed death due to reinfection. And then lastly here, just to wrap up the didactic portion from a summary standpoint, hopefully now you can understand that antimicrobial suppression strategies in infective endocarditis are very unclear, and the studies that have been published are very small in nature, and the patient populations vary so much that it's really hard to determine what to do overall. Rates of adverse events in the SATIE study were very low, although it was a small sample size and it may have been difficult to assess since it was retrospective in nature. And really, in this patient population, we truly need prospective studies to appropriately assess the impact of suppressive antimicrobial therapy in infective endocarditis. And then on the next slide here, I have my references, and definitely happy to take any questions that anyone might have.
All right, if nobody has any questions, I was doing the famous echo pause, but I think we're okay. So we can go ahead and stop the recording.